Good evening, everyone, and thank you for joining us tonight. My name is Jennifer Imerini, and I'm the Director of Medical Education at Zimmer Biomet. We are excited to host our second annual virtual Pectus Community Seminar. We are pleased to continue the partnership with Dr. Lasasso to bring you this educational program. Please join me in welcoming Dr. Barry Lasasso, who is from the Valley Hospital in Ridgewood, New Jersey. Dr. Lasasso has extensive experience in treating patients with Pectus Excavatum, and we couldn't be more honored to partner with him to host this event. The Valley Hospital is accredited by the Medical Society of New Jersey to provide continuing medical education for physicians. The Valley Hospital designates this electronic activity for a maximum of 2 AMA-PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Our faculty disclosures are Dr. Lasasso, Ms. Imerini, and Mrs. Tan have stated in the faculty disclosure form for the CME activity that the presentations will not include a discussion of a commercial products or services. The presenters will disclose any unlabeled use of a product discussed today. The planners of the activity do not have any disclosures. Other persons who influence the content of this educational activity do not have any financial arrangements with the manufacturer of a product or service. This activity is not supported by a grant. And lastly, members of the Valley Hospital Education Committee or CME staff who have the opportunity to influence the content of this educational activity do not have any conflicting financial interests to report. For participants, if you have any questions during the presentation, please feel free to use the chat feature at any time. We will collect your questions throughout the presentation and answer them at the end when we open it up for Q&A. With that being said, we are very excited to go ahead and open up the floor to Dr. Lasasso's presentation. Thank you.
Thank you, Jennifer. I want to thank Zimmer Biomet for their support in providing this educational material to the professional community. I am honored to be assisting you in that endeavor. And I want to thank all of my friends and all of my staff for their help in preparing this presentation this evening. And I want to welcome all of you around the country for your interest and participation in this material. I'd like to first start with giving you an agenda and an overview of tonight's presentation. I want to start with first giving you some information in general regarding Pectus deformities, share with you some of the conditions that are associated with this condition, discuss specifically Pectus Carinatum and Pectus Excavatum, talk a little bit about some of the clinical research that's been done to document the specific impairments that Pectus Excavatum can cause, talk about non-surgical treatment options and surgical treatment options. With regards to surgery, talk specifically about postoperative care and some of the clinical research that has shown improvement in patients' physiology following the anatomic correction of Pectus Excavatum, and then share with you a little bit of our patient education materials. Next slide. Pectus Excavatum Carinatum is a problem that affects the configuration of the anterior chest wall. On the far left in the diagram there, you see the relationship of the anterior chest to the heart and lungs, that being normal. On the middle figure, you can see where the chest is concave, it's sunken. The sternum is much closer to the thoracic spine, and the heart is both compressed and shifted to the left. In Pectus Carinatum, to the far right, you can see where the chest protrudes forward and the heart is in its normal anatomic position. Next slide. It's essential for you to understand that pectus of either variety is a genetically driven phenomena that affects the growth and development of the cartilaginous ribs in the front of the chest. It's more common in males. Its incidence is about 1 in 400 individuals. So on a sunny day anywhere along the beaches of the United States, your chances of seeing someone with one of these configurations is quite good. The diagnosis can be made shortly after birth, though the preponderance of patients will have a normal chest at birth, and then the deformity will become obvious as the patient goes through pubertal growth, somewhere between 8 and 10 years of age. 75 to 85% of cases are seen in Pectus excavatum. 15 to 25% of cases are Carinatum, sometimes referred to as pigeon-breastedness. Next slide. We're going to talk a little bit about the diagnosis of both Pectus excavatum and Carinatum and their concomitant conditions. Next slide. So as we've said, this is genetic predisposition coupled with growth. So in either excavatum or Carinatum, one generally has a family history. That genetic abnormality tends to be autosomal recessive in its inheritance. And in somewhere around 40 to 50% of patients in my series, there is a positive family history. It's important to understand that if one has this predisposition, as long as one is growing, one will manifest the condition until growth has stopped. So it is a continuum of growth and abnormal growth. About 30% of patients with this condition will have scoliosis. Next slide. Rarely, this will be associated with connective tissue disorders, the most common of which is Marfan syndrome. Patients with Marfan syndrome will have a very high incidence of pectus deformities, about 70%. The reverse is not necessarily so. Patients with Pectus excavatum rarely have Marfan syndrome. So the clinician needs to be aware of this association, and it's important that during the course of one's workup of a patient with a pectus deformity, whether it's Carinatum or excavatum, that connective tissue disorders are ruled out. A rarer form of connective tissue disorder, Ehlers-Danlos syndrome, is also seen in this patient population. The concomitance is unknown, however. Next slide. Cardiac conditions are quite often seen with patients with pectus deformities, the most common of which is mitral valve prolapse. It's seen in about a quarter of patients with Pectus excavatum. Next slide. Now we'll talk a little bit about the specifics of Carinatum, remembering that Carinatum is the lesser common of the two deformities. There generally are fewer symptoms. They tend to be more minor. As the chest grows and protrudes, There is often chest pain associated with that. We think it's because the chest is being stretched in a non-anatomic fashion, and that causes some discomfort for the patients while this is in evolution, in acute evolution. There can be some shortness of breath or tachycardia in severe cases, but predominantly it's mild pain that can be sometimes associated with the carinatum form of the deformity. The real issue here with patients with pectus carinatum is low self-esteem, poor body image, and the effect that the chest protruding has on the patient's self-image. Next slide. The treatment for this is non-surgical, and when it's diagnosed early in life, bracing is the first line of therapy. It's extremely successful. Upwards of 80% of patients with pectus carinatum can be successfully treated with external bracing. Early on in the process, the brace needs to be worn for the entire day, 20 plus hours. And in my experience, somewhere between 6 and 8 months of continuous wearing of the device will result in an excellent outcome. The most important thing for people to understand, for parents and patients to understand, is that compliance is everything with this technique. The brace doesn't work under the bed or in the closet. So it's important for you as the clinician to assess what you think the patient's compliance might be, how much you feel the patient understands the need for wearing the brace, and that will result in a good outcome, and just how committed the patient seems to be to this treatment plan. It's most effective for patients under the age of 18 because as the chest matures, it becomes more rigid, and bracing in a rigid, more adult-like chest is ineffective. So there's a sweet spot for using bracing. There's the time when the patient is old enough and mature enough to be compliant with the treatment plan, and yet not too old where their chest is rigid and is not conducive to external bracing. Next slide. The Ravitch procedure, which is the open operation for pectus deformities, is in my practice, the only indication for it is in the older patient that has pectus carinatum that can't be braced. So it's an open procedure. It requires a deconstruction of the chest wall and a removal of the abnormal cartilaginous ribs, which are affected by the carinatum process. Removing those abnormal cartilages and then securing the sternum in a corrected position using a small strut-like bar is the approach to carinatum in the older patient. Next slide. Pectus excavatum now, we'll look at treatment and diagnosis. So the most common symptoms are really exercise-induced. So at rest, most patients with pectus excavatum will have no symptoms at all, an absence of symptoms. But with aerobic exercise and with an aerobic challenge, patients will become short of breath. They progressively lose endurance. They develop what's called exercise intolerance, meaning that as they attempt to do more vigorous aerobic activity, they become more and more fatigued. They have an inability to keep up with their peers, and that's a very good question to ask patients in your examining room. How do they fare when they're doing aerobic activities like running track or running the mile, the timed mile? How do they fare against their classmates? How do they do at the end of an aerobically challenging game like soccer or basketball? That's a way of eliciting this symptom of exercise intolerance. Chest pain is seen. It tends to be a less common symptom than shortness of breath and exercise intolerance, but we do see it. Patients often will describe palpitations and tachycardia. They can have wheezing that sort of mimics asthma, but there is not the severity that you see in true asthma. They can have frequent upper respiratory infections. They fatigue easily. They can become dizzy and even faint. That is not an uncommon symptom of severe pectus excavatum. And of course, the psychosocial impact is exceedingly significant. These patients tend to avoid situations in which they're exposing their chest walls, and they tend to be somewhat withdrawn and not socially engaged as a result of their condition. Next slide. A little bit about the research showing the impairments that are physiologic. Next slide. So there's been a lot of research done looking at patients with significant pectus excavatum deformities, and it's clear from that research that there is a decreased cardiac output and a decreased cardiac stroke index with these patients. And it's important to understand why. Essentially, the right heart being closer to the anterior chest is directly impacted by the sinking chest. That direct impact of both compression and displacement affects right-sided circulation from the heart to the lungs, leading to inefficiency of that circulation, which subjectively the patients experience as shortness of breath and early fatigue. Next slide. There's also pulmonary function impairment, but I want to emphasize that the principal impairment secondary to pectus excavatum deformities is cardiac, not pulmonary. However, you can see in about half of patients, 40 to 50% of patients, there'll be a lowered forced expiratory volume, or FEV1. There'll be a lower forced vital capacity and decreased lung capacity. So all these patients require pulmonary function testing. Next slide. This slide indicates what I was discussing just a moment ago, that the psychological impact of this deformity can be severe. It worsens, in my experience, it worsens with age. Younger children are not as aware and are not as troubled by the deformity, but as patient's age, get into their mid to late teens and into adulthood, it can have an enormous psychological effect. So really, to me, this is a combination of significant cardiac impairment coupled with significant psychological impact in many, many patients. Next slide. I want to talk a little bit about the non-surgical treatment options. This is a device called the VacuumBell. It was initially devised by a group in Europe. It is a non-surgical option. Think of it as a large suction cup that goes over the chest wall, and by pumping it up like you would a blood pressure cuff, it creates suction. It's used on a fairly regular basis, usually about 30 minutes twice a day. It literally pulls the chest up into a corrected position, and it is very effective in the very young patient with a minimal deformity. In my experience, its use in adult patients or older teen patients is not as efficacious. Some surgeons will use it in the operating room to elevate the chest wall in making the performance of the Nuss procedure easier. And I use it occasionally in older patients before their operation to assist in creating some flexibility in the chest, making the chest more compliant, and increasing the efficacy of the internal Nuss brace or bar. Next slide. When is a surgical procedure for pectus indicated? Well, it has to do, of course, with the documentation of the severity of the deformity. And it also has to do with how that deformity is progressing and what are the associated symptoms. The figure that you see on this slide is that of a CT scan of the chest. This is the image where the sternum is closest to the thoracic spine. The Haller index or severity score is measured by measuring the transverse distance and the AP distance. That ratio in a normal person is around 2 to 2.5. When the AP distance lessens as the deformity becomes more severe, that larger number is divided by an ever smaller number, causing the severity score to increase. When it's over 3.25, then you have a deformity which meets the standard of care for correction. So 3.25 is a very important number. It's an arbitrary number. It's a number that we as providers have determined to be a point where most people with that severity have symptoms, and it's where we've arbitrarily set the minimum severity that warrants correction. The image that you see is a CT scan, but MRI and CT scanning can both be used. I personally prefer MRI scanning because it doesn't involve radiation. And furthermore, when you couple an MRI of the chest, which allows you to measure the severity score, with an MRI of the heart, you can now start to see how the displacement of the heart by the chest wall is creating abnormalities in the flow through the right side of the heart. And that's a great correlation to establish, both to help the patient and family understand how the deformity is affecting the heart, and also to document anatomically what the effect of the deformity is having on the cardiopulmonary circulation. As we said before, pulmonary function tests can also be abnormal, showing both a restrictive or an obstructive pattern. Cardiology evaluation is always part of the evaluation of a patient with pectus excavatum, and obviously it's often will reveal compression and displacement that can be seen on the CT or MRI, and also on the echocardiogram. Clearly, the results from the Nuss procedure are much more desirable and results in a much more likely good outcome than the open procedure, and I'll discuss that further in just a minute. Next slide. The surgical treatment options. I'd like to, at this point, go through the open procedure just briefly. This, again, is not an operation that I feel has a place in treatment of pectus excavatum at this point in time, simply because the minimally invasive operation has a greater efficacy with fewer complications. And so most of us who are doing this work with both young adults and adults are preferring to use the minimally invasive Nuss procedure as the operation of choice. But just for the sake of you understanding the differences, the Ravitch operation is a deconstruction of the chest wall. It's a removal of the deformed cartilages. It involves literally disrupting the sternum, realigning it after disrupting it, and then reconstructing the muscles over this over the chest wall that's been opened completely and the cartilage is removed. Generally, a strut is used to support the sternum during the healing process, and then it's removed at 6 to 12 months post-op. Next slide. The minimally invasive surgical procedure, or the Nuss procedure, is done using 2 small incisions on either side of the chest wall, as depicted in the illustration. This operation is always done using thoracoscopy, so that one can see where the deformity is relative to the heart, because the prosthesis, the bar, needs to go under the abnormal cartilages, below the sternum and above the heart, lifting the central portion of the chest wall forward. Remember, it's the cartilages adjacent to the sternum that are abnormal. So the internal brace, which is essentially what the Nuss bar is, will push the chest forward once it's positioned below the sternum and abnormal ribs. Next slide. So I want to show the Nuss bar. Here is the bar. It's been bent into this configuration. Each bar is bent to the specific dimensions of the patient in which it's implanted. The bar, from the end of the bar here, where my finger is, to here, is under the skin and can be felt through the lateral chest wall skin. And from where my fingers are, here and here, the bar is inside the chest, under the deformity and above the heart, pushing that portion of the central chest forward. So essentially, it is in this configuration, like this, and it is inserted through the incision on the side into the chest where one can see where the bar is relative to the heart and lungs. It's passed under the central chest and above the heart out to the other side, and then flipped into place and then secured. The securing of the bar is done in different ways by different surgeons. Because I was trained by Dr. Nuss, I do it in the traditional way where I use one stabilizer. This little bracket goes on the end of the bar on one side, which then allows for 3 points of fixation of the bar against the chest wall. Okay. On the other side of the body, the bar is then sutured around a rib where the bar crosses a rib. That's done with a special instrument and under thoracoscopic control. So the bar is both internally fixed to the chest wall and externally fixed to the chest wall, and that prevents the bar from displacing. Over the course of the first 4 to 6 weeks, the bar is encapsulated. It becomes coated with connective tissue, and it's the capsule that really holds the bar securely in the chest cavity during the time that the bar is in place, which for most patients is 3 years. Next slide. The benefits of the Nuss procedure are simply shorter operating times, less blood loss, smaller, less visible incisions, and reduced overall trauma to the body. And last but not least is that the recurrence rate of Pectus excavatum after a Nuss procedure, when done expertly, is almost zero. Whereas the recurrence rate in the open operation, depending on who you read, is somewhere between 10 and 15%. Next slide, please. Postoperative care. So immediately after surgery, patients are transferred generally to the post-anesthesia care unit, the PACU, where the patient is recovered and then transferred generally to a regular room. The length of stay is really somewhere between 3 to 4 days. 5 days is generally a long hospital stay for someone. It's generally closer to 3 to 4 days. And of course, the hospital stay is really all about managing any discomfort that the patient may have. And so pain management is a critical part of getting patients through their hospital stay in as good a way as possible. Next slide. 1 to 4 weeks after surgery, the patients generally have follow-up. I generally see patients a week to 10 days after surgery. There is limitations that are necessary for the first 3 months after discharge, in which time patients are encouraged to walk and deep breathe and do physical therapy, but not return to all normal activities. And clearly, once patients are discharged, their expectation should be that pain management will be necessary for another 1 to 2 weeks. Generally, the pain management includes some narcotic medications for that first week, after discharge, but after that, most pain can be managed with medications that don't include narcotics. Most patients can go back to normal activities within 6 to 8 weeks. And we always encourage, as I said, frequent walking and deep breathing and no twisting and basically maintaining a good posture. Next slide. Again, returning to normal activities at about 12 weeks, and patients are able to live a very, very normal life. I'm amazed by how once the postoperative and rehabilitative phase of care is completed, how these patients can return to any and all activities. Next slide. Bar removal usually occurs at 3 years from the original surgery. There is some controversy about this. Some people say 2, but most say 3. Sometimes I will leave the bar in a little longer than 3 years, especially if I put the bar in early in life and the patient is still growing. The important thing is not to remove the bar if a patient is still growing at a rate of greater than 1 inch a year. So for me, that is the defining issue, is to assess patient growth during the period of time when one is contemplating bar removal and making certain that the patient isn't growing greater than 1 inch at a rate of 1 inch a year at that time. Bar removal is an outpatient procedure. It does require general anesthesia, but most patients, like 99% of patients, can leave from the hospital the same day. And the approach to removal is by opening the lateral incisions and then opening the capsule at the end of the bar and straightening the bar, and then pulling the bar out of the chest in a straight configuration, which is done very simply, and then closing the 2 1.5 inch incisions on either side of the chest. So it's done from the portion of the bar that is external to the chest cavity. So it's a subcutaneous approach to the removal of the bar, which then results in much less pain management necessary for bar removal. Next slide. I'd like to share with you some of the clinical research that has documented physiologic improvements. This comes mostly from the adult literature. Next slide. We have seen unequivocally that there's an increase in the diastolic and systolic ventricular diameters, basically because you've relieved the heart of the compression of the chest wall, and that in turn results in increased stroke volume and cardiac output. It's important for all of you to understand that the symptoms are physiologic, that this condition creates pathophysiology, and that the Nuss correction reverses that pathophysiology. It also corrects the cosmetic deformity unequivocally, but the most important aspect of the correction is the reversal of the pathophysiology and reinstituting normal cardiopulmonary circulation. Next slide. We've also seen improvement in pulmonary function testing with higher FEV1s and vital capacities. Next slide. The satisfaction of patients that undergo this life-changing procedure is tremendously high. upwards of 80%. And I would say that most patients who undergo this procedure feel retrospectively that it changed their lives for the better. Next slide. Patient education. It's important to understand that patients have a lot of questions, and you, as the primary clinician or even subspecialist, may not have all the answers. There's this website, www.pectusbar.com, that provides an enormous amount of patient education. Zimmer Biomet has spent a lot of time and effort in developing this educational website for patients and families, and I would encourage you and your patients to access this information. I also have a website, www.nussprocedure.com, that has a lot of my own personal experience with this condition and the surgical correction, with a lot of before and afters. And I would encourage you all to go there and review some of the educational information that might be there for you. Next slide. This is some of the in-office patient educational materials that are available to you. And you can reach out to Zimmer Biomet or to my office for some help in getting this educational information. I would tell you that the information is very, very helpful to patients who are trying to understand what their options are for the correction of this deformity. Next slide. Thank you so much for your time and your attention this evening. We're going to now go to the questions that you may have. I want to thank you for your interest in this topic.
Hello, everyone. So at this point, we would love to open it up for any questions you might have. There are two ways to do that. At the bottom of your screen, you'll see a little chat icon with a one message from us, and you can type your chat in that way. If you prefer to raise your hand, you will also see a question, a box labeled participants. If you click on that, it will open a small window, and if you scroll all the way to the bottom, it will allow you to raise your hand, and I'll go through questions that way. So I'll be moderating the questions for you. If you logged one through the chat, I'll just read them out loud. If you raise your hand, I will unmute you when I call your name, and you can ask the questions directly, and that way it gives you time to also ask follow-up questions if you have more detail. So we'll start with the chat very quickly and go from there. Thank you. Except I can't see the window. All right. So first chat question will be, is there an ideal age to have a Nuss procedure, Dr. Lasasso?
Yes, there is. And again, I think this has something to do with both the physiology of the patient and also the maturity of the patient. So for most patients, by the age of 13, they are having generally some sense of this condition. They can participate in the decision-making that is entailed in deciding whether or not one should go forward with correction. And it's an excellent time to make an intervention because the patient generally at 13 has not completely expressed the deformity to its maximum extent. So for that reason, I say the sweet spot is somewhere between 13 and 15. The youngest patient I've personally done is 10. It was a patient who had a severe deformity with severe symptoms. Generally, the youngest I will do is around 12. The reason for that is because if you leave the bar in for 3 years, as we just discussed, a 12-year-old is then 15 at the time you would begin to think about removing the bar. Most 15-year-olds are still growing at a rate that would make it necessary to leave the bar in for additional time. Now, sometimes that's a decision that is in the best interest of the patient. So the 12-year-old sometimes is someone that you will, go forward with repairing. But the older patient, 13, 14, 15, once 3 years have passed, you're closer to the timeline for the end of growth and being able to remove the bar without worrying that there's going to be any further growth and risk of recurrence. So the short answer is 13 to 15.
Dr. Lasasa, the next question. Are there any conditions that will not meet the criteria for surgery for pectus excavatum?
Well, I think that you can have pectus excavatum, if I'm understanding the questioner's question. You can have pectus excavatum that is not severe enough to exceed that minimum threshold, but still have a chest that looks physically sunken. And in that instance, that's a time when you can do exercises, use the VacuumBell, and make interventions that are that can help in alleviating the sunkenness, the mild sunkenness. And so I would say that would be a situation in which you would consider exercise in the VacuumBell. If I'm understanding I think I'm understanding the question correctly.
Perhaps. Is there certain additional characteristics that would preclude you from feeling comfortable doing the Nuss procedure?
Sure. So I would say in the older patient, the adult patient, there could be concomitant morbidities that would make one think twice about proceeding with a procedure that is purely elective and meant to improve the quality of one's life. So I think it's important for the older patient with other medical conditions that might make a Nuss procedure more challenging, that the provider, the surgeon, be experienced in doing adult operations, doing adult Nuss procedures, so that the proper judgment could be exercised with regards to doing it only when there's more benefit than risk involved. But like any surgical procedure, it's important to weigh risk and benefit. And I can tell you that in older patients in particular, the risk can outweigh the benefit. And that's something that needs to be clearly kept in mind as one goes through the process of working the patient up. And it's important for the patient to have a provider who's experienced in dealing with this condition frequently and has experience doing it in particular with adult patients.
Thank you. Just to reiterate, and along the lines of this question, is there a perfect age to have the Nuss procedure?
Well, I think, again, I would say there's a perfect range of ages. I would say somewhere in the range of 13 to 15. If I had to give you a single number, I would say 13, mainly because a 13-year-old generally has a sense of the condition and can participate in the discussion about whether or not a operation should be performed, and is a willing participant in the rehabilitative phase of care, and is young enough so that they've not clearly manifest the full severity of the deformity. So you're not intervening at a time when the deformity is at its maximum. So there is some advantage in doing it at that age to avoid further deformity that may require more extensive corrective steps to be taken in order to achieve a good result, meaning being able to do it earlier in life with one implant versus later in life with multiple implants. The same outcome is achieved, it just requires more work in order to achieve it. So a younger patient can sometimes be corrected with a less extensive operation.
Thank you. So this question kind of goes hand in hand with the previous one, and we see it all the time. Is the Nuss procedure covered by most insurance plans?
Well, that is a great question. And I will just be honest with all of my colleagues out there. It does sometimes require a real effort on the part of the patient, the family, and the provider to work together to assemble the information necessary to convince the insurance provider that the benefit of this procedure would be significant for the patient. So yes, it is covered. Yes, it is covered. It is a covered condition. However, there are very, very specific indications for doing it that the insurance company will hold the provider to, and therefore the provider needs to do a thorough and complete workup and have the experience to present the findings to the insurance company in a way that is both accurate and compelling and allows the patient and family to proceed with the desired correction. So it does take effort, but it can be accomplished, and we do it all the time.
The next question is one that it might be better to actually have them ask it live, but Mr. and Ms. Miller, you had a question that said, I haven't had a patient get the procedure done in quite some time. In the early 2000s, we've had several patients in whom the bar bent within a fairly short period of time. Is this still a complication for you? So Dr. Lasasso, if you need more information on that, and if they're still in the room, which I can say they are, I'd be happy to unmute them and you guys can have a discussion about this.
Okay, well, I'll address that question. It's a great question. So Dr. Miller's, the operation has evolved over the course of the last 20 years. I did my first operation in 1999. So I've been doing this for over 20 years. I've done over 1,000 operations. And I can tell you that the operation has improved. The operation is improved in terms of our knowledge of how the bar should be bent, how it should be positioned within the chest and secured, how many bars are necessary, what things can we do to keep the patient safe during the course of positioning the bars within the chest, how do we manage the pain that is associated with the correction. So all of these areas have been areas where great strides have been achieved through the efforts of a provider community which is dedicated to this condition and to the patients who suffer from this condition. And I can tell you that we do a much better job in providing an effective operation now than we did 20 years ago. But I can tell you, I personally have never had a bar displace, and I have never caused the injury to an internal organ in performing this procedure. And so I think those kinds of questions need to be asked of providers doing the operation by patients, so that patients can be assured they are going to somebody who is experienced and capable of doing the operation that is required in order to achieve the best results. I can tell you the way you achieve the best results is going to people who do it often and do it over all age groups and all severities, and have a multidisciplinary team that supports them. This is truly a programmatic type of treatment. It requires a village to provide the treatment necessary for the patient to achieve the best outcomes. So it's important for you, the referring physician, and for individual patients and families to do your homework. Identify people who are doing this at a very, very high level of proficiency, okay? And those are the people that you should be directing your patients to, and those are the people who should be, answering the patient's questions and convincing them that they have the experience and knowledge and judgment to do the operation well.
Does that answer your question?
Hey, Dr. Lasasso, it's Steve Miller. Can you hear me?
I
Yes.
can. Yes. Hi, Dr. Miller.
How are you?
I'm good. Thanks.
I appreciate your explaining that. When the procedure was done on really several of our patients back in the early 2000s, it was just done by our local pediatric surgeon, who was very skilled, but we did see this several times, and it really shied us away from even recommending that the procedure be done. So that was the reasoning for my question. I figured that it was more a technical issue at the time than really an issue with the procedure itself.
Absolutely, Dr. Miller. If you bend the bar properly, and it's art. I mean, to get the bar into a perfect, configuration that matches the patient, it requires sculpting the bar so that it fits perfectly into the patient. Then you have to have good judgment and lots of experience to know where to place the bar and how many bars to place. And then you have to have the experience and skill to know how to optimally anchor the bar or bars in the chest wall. If any of those steps are not done optimally, then you have the potential for a less than optimal outcome. So that's where experience, judgment, and quite frankly, commitment of the provider and their team is so critical in achieving the best outcomes. Because this isn't an operation that should be done by someone who does it only a few times in the course of a given year. It's something that should be done by people who have an institutional and professional commitment to doing it. And they do it often. And by doing so, they do it well. And so I want to reassure you that in the right hands, any patient that you may see with a significant deformity can be safely reconstructed, and done so with great, with great assurance. And I want to reassure you that consider sending your patients, because to not send them is to then ensure that they will have these symptoms and physiologic condition, which can really affect the quality of their lives over the long haul. You know, I'm one of the few pediatric surgeons that also does adults. And so I see the effect of having pectus in the 3rd, 4th, and 5th decades. And almost a perfect storm develops over time, where as your aerobic capacity and fitness declines as a result of aging, which happens to us all, no matter how fit we try to maintain ourselves, there is a natural decline. And that, coupled with the cardiac inefficiency, the cardiopulmonary insufficiency, is a perfect storm later in life. And these patients often will complain of not being able to do the things they love to do with their children, their grown children, their grandchildren, etc. So it's really important that patients with the condition have a evaluation done and give them the opportunity to correct it once they learn what they need to know about their individual deformity and its impact on them physiologically.
Great, thank you very much. And if I could just ask just a quick follow-up question, just regarding the bar itself.
Sure.
Has the material composition of the bar changed significantly over the last 20 years? I'm just trying to get myself into the 21st century with this.
Sure, absolutely. So there are really 2 bars available to practitioners. There's a stainless steel bar and there's a titanium bar. With the stainless, and those 2 options have been available since, you know, the very, very early days of doing the Nuss procedure. Personally, I prefer to use a stainless steel bar because I can personally bend it. I can sculpt it. I use a bending instrument and I can bend the bar, you know, millimeter by millimeter to get it to fit perfectly onto the chest, okay? So I prefer doing that. It's sort of the artist in me. However, if you have a metal allergy, which about 13 to 15% of patients in the general population have, then that has to be identified. And we do skin testing on all patients who are to undergo the Nuss procedure. Therefore, if you do have an allergy to the most common alloy, which is nickel, then a titanium bar is your only option. A titanium bar is bent by Zimmer Biomet, or the company that supplies the bar, okay? And it has to be machined in by the manufacturer. And that's done in collaboration with the surgical provider, and is done using the CT or MRI as the map for bending the bar. So each provider has a certain, you know, configuration that they like, and if a titanium bar is needed, both the manufacturer and the provider need to collaborate on how, based on the imaging, the bar should be bent, and that's a conversation. And then once that's agreed upon, the bar is manufactured and sent to the provider. So that's the long-winded answer to your good question. There's a steel bar and there's a titanium bar.
Great. Thank you very much for your presentation. It was very good. I appreciate it.
You're welcome, sir. Thank you for your interest.
Have a great night.
Same to you, sir.
So, Dr. Lasasso, this is a question as well that comes up quite often, similar to the insurance question. What's the age of the oldest person you would feel comfortable doing the Nuss procedure on? And we know this is a double-ended question, triple-ended. There's all sorts of reasons, but you're one of the few doctors that will address the Nuss procedure in an adult at a certain age.
That's correct. So just to give you a little history, I was in the audience when Dr. Nuss presented his paper to the American Pediatric Surgical Association, and I was lucky enough to have a mutual friend of Dr. Nuss. And so after his presentation, I went up to him. I was introduced by this mutual friend, and I asked him, can I come and work with you? Can I come and learn this operation from you? And he's such a wonderful, gracious man. He was welcoming and allowed me to come multiple times over the course of a year to learn his operation, not only how to do the operation, but how to care holistically for these patients. And after a year of going back and forth between California and Norfolk, Virginia, where he did his work, I did my first operation, and I did purely children until about the mid-2000s. And suddenly the lay press was beginning to publicize that there was a new operation for patients with this condition. And so adult patients started to reach out to me with the condition, and their stories were very compelling. And I just felt, if not me, then who is going to deal with these patients who now are later in life having very significant symptoms which were affecting the quality of their life. And if I don't address it, then who will? So I began to see adult patients, and then slowly I created an adult center adjacent to the pediatric hospital where I was on staff. So I had both an adult and a pediatric program in San Diego from the mid-2000s until I came back to the East Coast in 2016. And what I learned from dealing with adults is that it's the same operation, it's just more challenging. That you're dealing with a more rigid chest wall, you're dealing with a deformity that is fully expressed itself in the adult patient, and you're dealing with patients who can at times have comorbidities. So it required another level of proficiency and expertise in order to meet the needs of this separate patient cohort. And so I began to do the 20-year-olds and then the 30-year-olds. And then as I did more and more of that work, the oldest patient that I did was 52 at the time of the operation. A gentleman that's on my website, you can go there and see pictures of him, a great man, and somebody who was extremely active and very debilitated by his deformity, and wanted to be able to continue to have an active life. He is from Alaska, so doing active things in the outdoors was something that he wanted to continue to do. And he flew down from Alaska to see me in San Diego, and I did his operation, which was very challenging. It required 2 bars, and I'm happy to report that he did very, very well. He's now maybe 3 years following bar removal, and I consider him one of the finer moments of my career, because it was a difficult operation that we were able to achieve an excellent result on. So 52 is the answer for the oldest, and 10 is the answer for the youngest patient that I've done.
Dr. Lasasso, is this procedure more complicated in females versus males? Are there any differences when you approach this surgery?
Oh, that is a great question. I love that question. So yes, it is different. It's different from an artistic point of view. So when you think about the difference between the male and female chest, you understand that the female chest tends to be slightly on the concave side, and males tend to be more on the sort of convex side, okay? And so with females, it's extremely important for the provider to understand that difference and be able to achieve the artistic result that the female chest requires as opposed to the male chest. So how I try to explain that to the lay person is that you want to slightly undercorrect the female patient, and you want to slightly overcorrect the adult patient. So there's a big difference in how you bend the bar with a female versus, male patient. And so it's important for the patient and the family to make certain that the provider who's doing it has done a lot of female patients if you're coming to that provider as a female. In terms of anchoring the bar, in terms of 1 versus 2 bars, that's pretty standard. I find the most important thing is the bend of the bar. That's the big difference between between females and males. And that's true whether you're a teenager or you're in your later years, you're an adult.
Dr. Lasasso, this is a question that comes up fairly frequently on our community seminars for patients, which we host monthly. Do you still do the Nuss procedure for patients who have syndromes, including Marfan's or Ehlers-Danlos?
The answer is yes. It's not an absolute contraindication to have a connective tissue disease and undergo the Nuss procedure, okay? What's important is that you're screened. If you do have a connective tissue disease, it is identified. That's extremely important before you undergo the procedure, that you rule out any aortopathy, meaning a dilatation, an abnormality of the aortic root. Extremely important to identify that preoperatively. And to make sure that patients understand that the response to the bar, if you have a connective tissue disease, can be different than if you don't. And by that I mean patients with connective tissue disease that have undergone the Nuss procedure will often have a sort of an exaggerated response to the pressure of the bar. So the bar is meant to bring the chest forward into a corrected position. However, if you have a connective tissue disease, the force to bring you into correction can sometimes cause a connective tissue patient to overcorrect, to tend to become almost Carinatum-like. And so it's essential that in patients with connective tissue disease, you not over correct them. And if they begin to have that exaggerated response to the bar, that you consider removing the bar sooner than 3 years. That would be a situation in which I would remove the bar at 2 years rather than 3 years if the patient were showing signs of this, exaggerated response to the bar. Any other questions?
Dr. Lasasso, how do you determine the number of bars needed on a particular patient?
That's an excellent question. It's really an intraoperative decision. So the approach, and this has been true since Dr. Nuss first described his operation, the first bar needs to go under the severest point of the deformity. And by that I mean the bar needs to go in under the deepest part of the deformity, where the chest wall is closest to the spine. Okay? You want to put the first bar there. And then you assess thoracoscopically by looking inside the chest with the telescope how the chest wall has responded to the force of that first bar. The objective being that you want to get the chest wall up and off the heart, okay? So that's very obvious when you look through the thoracoscope at the resultant anatomy. So if the first bar lifts the chest wall up adequately such that you've corrected the chest wall deformity and the chest is up off the heart, then you're done. If there's a remaining portion of the chest wall that is still sunken and is close to impacting the heart, then you put another bar in. And the bar goes either one above or one below where the deepest part of the deformity is. And the chest wall dictates that. And you can see that through the scope.
Dr. Lasasso, when do you expect to be doing the next community seminar, such as we're doing tonight, or we also have patient seminars on a monthly basis normally?
So I'm going to do a really great one at the end of the month where I'm going to talk a little bit about how sports and Pectus interact, and discuss specifically through the eyes of a few very accomplished athletes who I've had the good fortune of treating over the years, through their eyes, what it meant as an athlete to undergo the Nuss procedure. So that's my next community seminar, and that is going to be the last Thursday of this month. Help me with the date. It is...
I believe it's the 29th.
The 29th. It is exactly the date.
You can always find more information on our website, nussprocedure.com, and that will allow you to register and sign in as well.
And I hope that'll be really interesting to a lot of young athletes who are out there in the chat rooms of the various support groups, wondering about whether or not they can undergo the Nuss procedure and still have an athletic career as high school or college athletes. So I wanted to address those concerns. I wanted to address those questions. And I wanted these athletes, in their own words, to be able to describe to their fellow athletes what it meant for them to undergo this life-altering corrective procedure. I am working with Zimmer Biomet to look for another professional-based webinar. I'm hoping to do that in the next couple of months. I'll keep you posted, and we'll have some information on my website as to when the professionally based next seminar is to be given. But we've had a wonderful response to these webinars, and it's been so gratifying to me that I've been able to reach out to the primary care community and provide pediatricians and primary care physicians of all kinds with the information that is necessary in order for them to identify the various types of pectus deformities, provide them with the basic information necessary to help them direct the patient to an appropriate provider, specialty provider, so that this workup that is so vital to these patients and families can be done in an expert fashion, and they can have the specific information that they so need in order to make that next decision, which is, would I benefit? Would the quality of my life be enhanced by having this corrective operation? So
Dr. Lasasa, we have a couple more questions. So
right ahead. I'm sorry. Go right
no
ahead.
problem. So Lori, you have a question for us, and it's what's the recovery like and how long? I'm going to let Dr. Lasasa answer this question, but we also do have a number of previous webinars on our website, nussprocedure.com, that will address that in more detail. But Dr. Lasasa, what's the recovery like from a Nuss procedure and how long?
Great. So the operation, from the day of the operation to the time of discharge from the hospital, is generally 3 to 4 days, okay? When you're discharged home, you generally are encouraged to walk and deep breathe as the sole exercise that you do for approximately 3 weeks. This is during the acute phase of healing. Once those 3 weeks have passed, the wounds are healed. You're walking comfortably about 30 minutes, 2 to 3 times a day. Then you're ready to undergo physical therapy. I have a complete physical therapy program that I have developed with an excellent physical therapy practice in San Diego. And that program lasts for 8 weeks. So for 16 sessions, twice a week, for 8 weeks, you undergo physical therapy. That gets you to a point where you're about 3 months post-op. You come see me. If you're doing great, you can then begin to do sports-specific exercise and return to competitive sports, depending on your sport, somewhere at that 5 to 6 month mark. And then you come back and see me yearly until the bar is removed. That's essentially the continuum of care.
All right, we have another question, Dr. Lasasso. Do patients who have undergone surgical correction of this condition at an early age need surgical revision due to advancement of their age later on?
Great question. Once corrected, the correction is permanent. That's the key. Once corrected and corrected optimally, the correction is permanent. Now, getting to the optimal correction is where, the rubber meets the road. You have to do a good operation, get the patient through that process and the bar out at the appropriate time. But at that point, if the correction is optimal and you've waited the optimal time, then going forward, there should be no need for any further surgery, and your correction at that point should be permanent.
Anybody else have any questions that I can add answers to? If you'd like to raise your hand and ask live, I can definitely unmute you, or you are allowed to unmute yourself. We've appreciated everyone who's attended. Dr. Lasasso, do you have any final comments?
I just want to thank Zimmer Biomet and my amazing team that surrounds me for the support and help in providing this information. And thank you, the audience, for tuning in, and I hope this has been a very profound educational experience for you. And if you have any further questions or concerns, please reach out to me directly in my office. I'd be more than happy to discuss with you individual patients and individual concerns that you may have.
Thank you, everyone. As follow-up, we host all of the recordings from our webinar series on our website, nussprocedure.com. This one will be up within the week. And thank you, Dr. Lasasso, for your time. Thank you, everyone, for all of your lovely questions. And again, we're always available. Our phone numbers are on our website. Zimmer Biomet would love to speak to you as well. And we will be sending out the CMA credit codes via email. So whatever you emailed as your registration address, they will follow up with your CMA credit information. Does that answer that question? Perfect. So, and also feel free to reach out to us. Again, our information's on our website if you have any questions regarding anything you've heard tonight. Dr. Lasasso, final comments?
Thank you very much, Kate, for your technical expertise and for your help in getting this launched today. I really appreciate it. Thank you so much.